Hi, I'm Alisa Brownlee. I'm an Assistive Technology Specialist with the ALS Association, and I thank you for joining me today for this presentation on assistive technology for people using invasive and non-invasive ventilation. So when thinking about assistive technology and invasive and non-invasive ventilation, obviously the first step is to talk about your respiratory plan, because each individual's experience with ALS can vary, and so too will their decisions regarding respiratory care. So your multidisciplinary care team or your healthcare provider can help guide a person with ALS and their family through this process. ALS will eventually weaken the respiratory muscles, and that will make breathing more labored. It's not uncommon for people with ALS to experience shortness of breath due to decreased lung function and diaphragm weakness. And as the breaths become shorter and shallower, the body receives less oxygen and is less able to expel carbon dioxide. So this can lead to fatigue, anxiety, headaches, lightheadedness, poor sleep, and bad dreams. Muscle weakness can also lead to hypoventilation, a state which the lungs fail to adequately expand, and sometimes this can increase your secretions, making breathing more difficult. So we use non-invasive ventilation, NIV, and what that refers to is the administration of ventilation support through the upper airways without using invasive artificial airways like a tracheostomy. So what people on NIV use is a face mask, as you can see pictured here, that usually goes over their mouth and their nose. It is easy to handle, it can be used at home. You know, most people start initially at night and then they may use it during the day. And that day use is where we can talk about communication issues, because it's very difficult to communicate if you have a full face mask on. And we'll talk about that as this webinar progresses. So the aim of NIV is to compensate for diaphragm weakness and alleviate carbon dioxide tension symptoms and improve patients' general condition and quality of life. NIV is associated with improved survival rates and better quality of life for people with ALS. And you can use NIV in your home, but you can also use it out in the community because it does have a rechargeable battery. In terms of invasive ventilation, this is a surgical procedure where a tracheostomy tube is placed in the throat, as you can see in this slide. And the procedure will prolong your life, but it can come at great expense to a person with ALS and their families. And it's important to understand that ventilator support does not slow the progression of ALS, so the disease will continue to progress. The individual decision to undergo a tracheostomy is a very personal one, and people often need a lot of time to think about it and what would life be like if I was what is called trach-invented, which means you have a tracheostomy with a ventilator tube coming out of your throat, as you can see also pictured on this slide. It is best to make this respiratory decision well ahead of time, while the person with ALS can still fully express themselves and ask questions and discuss all the ramifications of this decision with their clinic or chapter team. In the United States, fewer than 10% of people with ALS do opt to get trach-invented, and it is important to talk to your loved ones about this decision, because unfortunately Medicare and most insurances do not pay for people to come to your home to take care of you if you are trach-invented. So the majority of your care will have to be by your family and your friends. And even if you do have coverage, we are in a severe shortage of workers right now. So you might have X amount of hours that your insurance will pay for, but you simply cannot find a trained professional to take care of you. And the majority of trach ALS patients are unable to speak. So we are going to address the communication issues when it comes to NIV and invasive ventilation. But before I talk about that, I want to talk about the importance of seating and positioning. Proper seating and position is critical for breathing, for communication, for computer access, for weight shifting, and basically just for living. Proper seating and positioning improves a person's ability to see more of their surroundings, to breathe and swallow and have better digestion. It allows for more comfort and less fatigue and greater ability to interact with the environment. And it distributes your weight so that you don't get skin breakdown or pressure ulcers. And it reduces your risk of falling. But for communication, it's extremely vital because you can't be in a listing position like it's pictured here on the slide. You have to be seated upright to use a communication device, but also just when you're seated upright and you're in a 90-degree position, it's also easier to breathe. And we have a lot of our folks that are in power wheelchairs, and they find that it's even more comfortable to sleep in their power wheelchairs than it is on a hospital bed. Sometimes that is because of breathing issues, because people who are short of breath, you're going to elevate your head. But the wheelchair has functions like a tilt in space where you can tilt back and open up your airway a little bit, and you can also, some of them also recline almost into a position like a bed. So people who are using NIV, that's non-invasive ventilation, that still speak, as I mentioned in my previous slide, some people will opt to use NIV during the day. And what ends up happening is they can't communicate because they have a full face mask on. So if they can still speak, they'll take the mask off, speak, put the mask back on, take the mask off, put it back on, and that's really defeating the purpose of having the non-invasive ventilator on. So if you can still speak and you're using non-invasive ventilation, what you might want to try is an amplifier. And there are amplifiers with what's called a transdermal microphone, and that's what's pictured here down on the slide to the picture on the right. And the microphone goes around the client's vocal cords. So the microphone is resting on the vocal cords, and with the amplifier, the person can now speak. So they don't have to take the mask off to speak. You always want to have a call system for in the home. This is especially important at night when you are using your non-invasive ventilator or even your invasive ventilator, that you can get somebody's attention in the home to call for help. So the most common call bell system that we use is the MedLabs Easy Call Bell and Alarm. That's the one that's pictured down here on the right, and it has a blue button which only takes a ½ ounce of pressure to activate, and it's plugged in to an alarm that goes beep until the client stops pressing that button. You can also use baby monitors that have video or non-video, and so especially if your loved one is sleeping in a different room, so you put the Easy Call Bell and Alarm on the person with ALS, and if the caregiver is in a different part of the house or sleeps in a different room, they carry one of the baby monitors with them so that if the person with ALS rings the bell, the caregiver can hear the alarm go off no matter where they are in the home. If somebody still has hand function, you can use wireless doorbells. You can get these at a home improvement store, Lowe's, Walmart, and they cost about $15. So the person with ALS has the small portion with the button, and wherever the caregiver is, they're going to get a ding dong wherever they are in the house. There are adapted wireless pagers, and these can either make a chime or they can vibrate. So if somebody has a hearing impairment and they might not hear the chime, the caregiver can wear the pager, or they can put it in a pocket, or they can clamp it to their jeans or their pants, and they can feel a vibration instead of hearing a ding-dong. You can use electronic doorbells or webcams as a signaler for help, or actually for just a caregiver to make sure that their loved one is okay. So these units hook up to a smartphone so that the caregivers, say they're out grocery shopping or they're out with their children, they can drop in and make sure that their loved one is okay. They can just hit the electronic they can actually activate the app and see the camera that's either in the home or wherever you've put it to make sure that your loved one is okay. Smart speakers are great for calling for help, but also for actually just being able to activate a smart home or even change the television channel. But in terms of calling for help, if one person has an Amazon, I'm going to use Alexa as an example. If they have that in the room where the person with ALS is, and then in another part of the house they have another Echo product, and they have the ones that have screens that are pictured here, they can see each other and make sure that they're okay. They can call for help. So I have both an Amazon Echo and I have a Spot. The Spot is the one that's pictured in the middle. And what I can do is I can be downstairs, and that's where my Echo is, and I can tell Alexa, I'll say, Alexa, drop into the Spot. And so what that does is it activates the Spot's screen, and I can see what's happening in the room where my Spot is. Also, as I mentioned, smart speakers do give a person the ability to control their home. So there's so many different functions that you can do through your smart speaker. Television, you can look at the Ring doorbell that I just showed you. You can lock and unlock a door. You can activate a fan, lights. So they really do give a person with ALS the ability to control their home environment, all through the use of a smart speaker. So I mentioned that for most people that are using invasive ventilation, the majority of them cannot talk. So we're going to address the communication options for people with ALS. And this is, of course, if you have a tracheostomy, but also applies for those that are just having difficulty speaking, slurred speech, which is called dysarthria. So our options for augmentative and alternative communication are rapid access. So these are easy, fast, efficient methods of communication that don't plug into a wall. You can use high-tech traditional mainstream devices like iPhones, iPads, Android tablets, and laptops. Then high-tech SGD, speech generating devices that are paid for by insurance. And what is important to know is that most people with ALS, when they have a communication difficulty, they will use multiple modalities of communication depending on where they are. The method of communication that you're using in the bathroom is going to be different than what somebody's going to be using in a living room or out in a community. There is no one system that people use. It's going to be multiple systems. And it is important to know that most of the communication breakdowns that happen in the home happen in the bathroom and in the bedroom. And if somebody does have an augmentative communication device, or if they're using their tablet, most of the time in the bedroom or the bathroom, that's where they don't have the device. That's where the communication breakdowns happen. So know that you're going to have to use multiple different systems depending on where the individual is. So the most important thing when it comes to establishing a communication system is that you have to establish a yes, no, and a maybe system. Please don't just ask yes and no, because you are forcing the person you are communicating with to answer incorrectly. So for example, if somebody said to me today, do you want to go outside, yes or no? Well, I don't know, is it raining? But I didn't give them a maybe. I just said yes or no. So always establish a yes, no, maybe system. You can do that through eye blinks, 1 blink yes, 2 blinks no, 3 blinks maybe. It's not my preferred method just because sometimes I miss a blink. Instead, I will usually stand at the foot of the bed or in front of the person, and I put my hand out to the right for yes, I put the hand out to the left for no, and my hands above my head for maybe. So I'm just watching their eye movement. But regardless of where the way somebody is saying yes, no, and maybe, always have it written down and hung on the wall. Because if somebody doesn't even know how to ask you these basic questions of yes, no, maybe, they're not going to be able to communicate with you. It's also important to put it on the wall in case you have to call first responders, that they can look at a person with ALS and say, okay, John, I see you say yes, bye. Okay, so the first responders are coming in. They're saying, John, are you in pain? Yes, okay, all right, and then they can just establish where. So rapid access can be the use of letter boards and picture boards and magic slates, boogie boards, eye gaze boards. Laser pointers are great. So you can mount a laser pointer on a hat or on a headband, and a letter board, which you can make on your own with a piece of poster board that costs less than $1 at Walmart. You put the alphabet or you put frequently used phrases and sentences on the poster board, and you can put that all the way across the room because a laser pointer can go a great amount of distance. So the person with ALS can be sitting halfway across the room and still spelling things out on the letter board. So you can see here's pictures of various different types of rapid access. In the middle is a picture of a laser pointer, and then there are letter boards pictured here as well as a boogie board. And what a boogie board is, it's an LCD tablet basically. So you write on it, you press a button, and what you wrote has gone away. And you can buy them on Amazon for about $30. So these rapid access technologies are really important for emergency preparedness, because if you call an ambulance and you end up in the emergency room personnel needs to know how to talk with you. So just them knowing how you say yes, no, maybe is important, especially now during COVID. These rapid access methods can be used for an inpatient hospitalization if you are emergently placed in a nursing home, for emergent ventilation. So if you haven't made a decision about whether or not to go on mechanical ventilation and you end up short of breath and calling an ambulance, and then you're taken in the hospital and given a decision, you either have to go on a vent or go home on hospice. And some people go, okay, I want to go home. I want an emergent ventilation. So that will be an emergency surgery where the tracheostomy is placed for you. And a lot of times that happens emergently. So, how are you going to communicate after this surgery? Rapid access is also important for mandatory evacuations. I think we've just this past year seen the devastation that's been happening in between wildfires and hurricanes and tornadoes. So sometimes you need to leave the house immediately, and so using these yes, no, maybe systems and letter boards are extremely important if you have to leave your home or if you have to stay in a shelter. So teaching people this method of communicating with you can literally save your life. And I don't say that to be over dramatic. I say that to be truthful, that It's a simple method of communicating with you, but you need to be able to relay crucial information to first responders, your medical team, and your family so that you can get your needs and your wants met. So there are devices that are funded by insurance. And AAC devices, AAC means augmentative and alternative communication. What that means is you augment your speech. So if somebody can still speak and they might have slurred speech, or they might get too tired during the day that they can't get enough breath out at night to speak, so then they'll grab their device. So that's augmenting your current speech. It becomes alternative when the client has absolutely no speech at all. So AAC means augmentative and alternative communication. In 2001, Medicare started paying for AAC devices. They were never funded prior to that. And at that time, Medicare called AAC devices SGDs, speech generating devices. So the terminology is interchangeable. I'm more old school, I still call them AAC, but if you are doing internet research or if you're looking at literature and it says SGD, it means the same thing. So insurance does fund these if you have Medicare with Part B and a supplemental insurance, and then some private insurances will fund either 100% or a portion of these devices. All private insurances follow Medicare guidelines. So Medicare has deemed SGDs or AAC devices are covered if the patient suffers from a severe speech impairment and the medical condition warrants the use of this device. So they are devices that can only be used for speech output. The devices cannot be useful to somebody without a speech impairment. That is a Medicare criteria. So Medicare does not cover personal computers, tablets, mobile devices that may be programmed to perform the same functions. All right? So that's really important because Medicare and insurance will only fund devices that have been deemed medically appropriate. And this is really important, that insurance will only pay for current needs, not future needs. So if somebody has decided, yes, I want to be mechanically vented, and they make that decision early, we as healthcare professionals, sure, we would love to get you all the medical equipment that you need prior to the surgery. But we can't if you can currently talk, because insurance only pays for current needs. And as the previous slide says, AAC devices are only covered if somebody has a severe speech impairment. So we can't get you that communication device prior to getting a tracheostomy if you can still speak. We can get it afterwards if you come out of the surgery and can't speak. So what you can do prior to getting mechanically ventilated, if you can still speak, you can obviously use a smartphone or a iPad or any other device that has a communication app, and then hopefully as you come through the surgery you can continue using it. But if not, there are loaner programs that you can borrow from both ALS chapter and an organization called Team Gleason. So for people that have slurred speech already, then yes, we can certainly go through insurance and get you an appropriate device. If somebody can use their hands, they can use what's called direct selection, so that's just using your hands to activate the device. If you do not have hand function, your options are to use a head mouse or an eye gaze. We're going to be talking more in depth about those in a couple more slides. But both the head mouse and the eye gaze can be added on later when clinically justified. So if you have slurred speech and need a communication device, you can get a tablet like pictured here on the right, and then we can add on the eye gaze or the head mouse later. And it is important to know that eye gaze devices are not funded unless the speech language pathologist can document that there are no other access methods. So again, we would love to be proactive and get somebody an eye gaze device, which is a device that somebody uses simply by eye activation, but that is not funded under Medicare or insurance until the speech pathologist can say, nope, they can't use a head mouse and they can't use switch activation. So yes, it's medically justified to get an eye gaze. So as I mentioned, AAC devices are funded under Medicare Part B, and your supplemental insurance would pay for the 20%. If you don't have supplemental insurance, you will owe the 20% because Medicare only pays 80% of the cost of durable medical equipment. With managed Medicare, most often you will get 80% of the coverage. Medicaid will vary from state to state. In Pennsylvania, we do have people getting devices funded under Medicaid, but I'm not sure about New Jersey, and Delaware often will pay for AAC devices under Delaware Medicaid. And your private insurance will just depend on your coverage. Sometimes you'll get 50% of durable medical equipment covered, sometimes it's 80%, sometimes it's 100%. It just depends on what is covered. And that is determined by what's called a rider. And every insurance policy has a different rider. So you have to call your insurance. Say you have Blue Cross. You need to call and say, what is my coverage for durable medical equipment? They might say it's 100% as long as you stay in network. Okay, that's fine. You might find out it's 60%. You might find out that you have no durable medical equipment coverage. So do not assume that you have coverage for durable medical equipment, which would include not only communication devices, but wheelchairs and commodes. Always call your private insurance and ask. And the Veterans Administration will fund communication devices as long as the individual is enrolled in the VA system. Communication devices are not covered if a person lives in a nursing home or is on hospice. So if you have a client that is residing, or if you have a person with ALS that is living in a nursing home, you can find out if they can get a device through Medicaid, or if they have private insurance, that might be covered. They are not covered, though, if you are only in a nursing home and have Medicare. So there are loaner devices that are available through the ALS chapter, as I mentioned, and then through an organization called Team Gleason. Just so everyone understands the process, if you want to go through and get a device from insurance, you have to be seen by an SLP, a speech language pathologist, who will do what's called an AAC assessment. So these are specialized assessments. Not every SLP does them, so you might have to go to a specialized facility to get this assessment. And I don't want to go through the minutia of the process, but just know that it takes quite a bit of documentation, and it's a comprehensive assessment. The SLP has to review everything from your medical history to your vision, to your hearing, to your caregiver's vision and hearing. They have to establish that you have no language issues. So it is a very intensive process that can take a couple of hours to do this assessment. And then after the assessment, the evaluation is sent to your prescribing doctor who has to sign off on it. That doctor has to do a chart note, which is called a face-to-face, and has to also issue a prescription. Then everything is sent back to the speech-language pathologist, who then sends this to the AAC vendor, who then bills insurance. And then once it's approved, you get your device. But I usually try to tell people this could be a 2 to 3 month process from start to finish. So from the time you go for the assessment to the time the device gets delivered to you. These are just some of the different eye gaze manufacturers that are in the United States, and they all do take insurance. Now, when it comes to mounts, communication devices that are funded under insurance can sometimes be heavy if they are, especially the eye gaze devices, you know, it's like 5 to 8 pounds, give or take. So you do want them mounted on a wheelchair, obviously to keep them safe and to prevent them from falling off. In the past, insurance has only funded one mount, and in the middle, as you can see here on the slide, is a picture of a rolling mount, and it's quite a large mount. Of course, it can roll around the house, but it's not really convenient to go out into the community. So then some people will say, oh, I want a mount that mounts to my wheelchair. Okay, but if you get one mount and it only mounts to the wheelchair, then the mount doesn't transfer if you're in a hospital bed. So you can try to ask the speech pathologist to get 2 mounts from insurance, or you can get a mount like it's pictured over here on the right. That's called a mountain mover. And actually it has a clamp that goes onto the wheelchair, and then the caregiver can unscrew or unscrew the clamp and then put it into a different clamp that goes on to the side of a wheelchair or onto the side of a bed. Onto the side of a bed or onto the side of a table. So the mount can go from the wheelchair to the bed or the recliner or wherever else the individual with ALS is. So some people will opt just to use mainstream technology like an iPad, an iPhone, whatever they're comfortable with. They might use this technology because they don't have insurance, or maybe, as I said, they're just comfortable in their current technology. Or they'll use alternative technology because they live in a nursing home or on their hospice and they know they can't get a device funded under insurance. So you can use an iPhone or an iPad, and there are different communication apps. You can get verbally for your iPad for free. You can get other iPad and Android apps for about $14.99. I love the app called Speech Assistant. I think it's a great app. And all these apps enable you not only to type out what you want to say, but they also enable you to say frequently used phrases and sentences, and you can bring them up and just press a button and it'll say, I need my eyeglasses. Many of these communication apps come in different languages, and if you do need a list of the alternative languages it comes in, please email me. You can access the iPad with your fingers or a stylus. You can buy a stylus of Five Below if you want to. But also built in to the iPad is called switch access. So that option is under accessibility. So when you turn on iPad switch access, you do need an interface. As you can see, there's one pictured here, this little black box, and you put a switch into it, and I'll talk about a switch in a second. And that black box acts as a Bluetooth interface. So when somebody presses their switch, the iPad will scan. It'll scan as you see pictured here. It'll go row, row, row. I hit my switch and it goes column, column, column. I hit my switch until it comes to the icon that I want. So that switch software is already built into the iPad. The only thing that you need is the interface and a switch. And so what is a switch? It's a piece of equipment that sends a current to the machine to do something. So picture a power wheelchair and a joystick. When the person presses the joystick forward, it sends a current to the machine to go forward. That's the same thing a switch does. It just sends a current to the machine, in this case an iPad, to do something, and it will start scanning. All right, so switches come in a variety of shapes and sizes. They can be placed anywhere on the body where there is muscle movement. In the new iPhones and iPad Pros, so you need an iPhone 10 or above, there is a front-facing camera, and there are apps that utilize that camera to activate eye gaze. So you can see the communication apps here. I Have a Voice and Hawkeye, Predictable, AAC, and Jabberwocky. They all use the front-facing camera so that you can, or on the iPad Pro or the iPhone 10 or above, so you can have the device in front of you, and it is reading your eyes to make activations on the screen. However, these communication apps only do communication. You can't use them for total access of the iPad. At the moment, that is only achievable through a product called the Skyle, and it's around $3,000. It's probably going to come down in price. It hasn't been around too long, but it does offer the individual total control of the iPad with their eyes. There are mounts that you can buy for iPads, iPhones, and Android devices off of Amazon, and most of them have a clamp so that they can go from wheelchair to the side of a hospital bed easily. If you're using an Android tablet, your access to Androids can be by a finger, by stylus, by a mouse or head mouse, or an eye gaze. So you have more access options on an Android tablet than you do on an iPad. You can also use a laptop for communication. There is free software that is available for Windows laptops that will basically turn your laptop into a communication device. If you can't use your hands, and if you still have good head movement, you can use a head mouse, which replaces the standard computer mouse for people who cannot use their hands. So what a head mouse does is it translates natural movement of a user's head into proportional movements of the computer's mouse pointer. So basically you are moving your head around the screen and making activations. What you end up doing is having a on-screen keyboard, and I'm sure we're all familiar with them. If you use a smartphone, you have your on-screen keyboard. That's how we send texts on a smartphone or a tablet. So you bring up an on-screen keyboard, which is already embedded in Windows and Mac. So you bring that up. You have a head mouse, which you have a receiver on the top of your Android tablet or on your laptop, and the user wears a reflector dot between their eyebrows, and so they are just moving their head around the screen, dwelling on the letter A, and it types the letter A for you. So it works just like a computer mouse, but instead of your hand moving the mouse, your head is. There is eye gaze control for computers. These are devices that turn any laptop or desktop to an eye gaze device. The more high-end are around $2,000. But know that Windows 10 has eye gaze software already pre-installed. So you can get an eye gaze bar. It used to be a Tobii 4C, I think it still is, for about $250. You can plug that into your USB port on your Windows computer, and you have eye gaze control of your Windows 10 computer. Of course, it's not as precise as the one that costs $2,000, but it does give you the option of seeing even if eye gaze is something that you want to do. And as I mentioned, there's free software that will convert any text that you enter into your Windows computer, and it'll say out loud. So each Equist is one. This is an example here. And again, this is free, so you can save frequently used phrases and sentences. You can write your own dialogue, And it also has fast fire, so that if I hit F1, it'll say, hello, how are you? F2 will say thank you, and etc. So some people that are on mechanical ventilation may develop locked-in syndrome. We don't have an exact statistic of the amount of people that develop locked-in syndrome, but it is something to be aware of, that locked-in syndrome has two formats. You have LIS, which is locked-in syndrome. It's the complete paralysis of all voluntary muscles except for eye movement. And then you have TLS, total locked-in syndrome, which is the absence of movement, including eye movement. So if somebody could still be technically considered LIS, locked in, but if they have eye movement, they could be able to answer yes, no, maybe questions and still might be able to use an eye gaze system, an electronic eye gaze system. People that have total locked-in syndrome have no eye movement, so there is no technology that has been developed that's commercially available yet that will enable somebody that has TLS to communicate. So it is important that you have your advanced directives written down and given to your family and your medical team prior to developing TLS. Now, as I mentioned, we don't know who might develop TLS, but always think of it as, okay, it might be something to consider. So I want my wishes known prior to that happening to me. And then with TLS, there also might be some eyelid issues and the person might not be able to hold their eyelids open anymore. And you do not want to tape them open because that can lead to torn retinas. So what is on the future for people with TLS and locked-in syndrome is brain-computer interface. This is in research only. And if you are interested in seeing more about this, I encourage you to go YouTube, look at some YouTube videos on brain-computer interface. It's also called BCI because they are making tremendous strides. And basically BCI is harnessing the individual's brain waves to activate a computer or a communication device. And I just want to finish up talking about emergency evacuation aids. These are aids that will get you out of the house in the event of an emergency. Everybody with ALS should consider having an emergency evacuation aid in the home. And this can be as simple as this tarp here that's pictured all the way to your left. This is about $55 for this evacuation tarp, which enables one person to wrap the individual up with ALS. I describe it like a burrito and pull. But it's not going to be comfortable per se for the person that's being pulled, but it will get you out of the house in the event of an emergency, whether or not that's fire or whether or not that's flood or a tornado coming. There are evacuation aids that are developed for the one in the middle. The blue one is developed for 2 people, and the picture on the bottom depicts that. So you have one person carrying the tarp at the knees and then the shoulders, and then the person on the other side is doing the other knee and shoulder. So, I can't say it, shoulder, there we go. And the picture on the right is basically just a backpack. It's a piggyback tarp that you put the person on your back and out you go. There are emergency evacuation chairs. These are chairs that are developed to get you out of the house or apartment or high-rise in the event of an emergency. And they come in several different forms. The pictured chair here that is yellow, you can see to the far right is just somebody being strapped in and taken down the steps. You will see these evacuation chairs a lot. Most of the schools have them. You see them in high-rises now. And the picture in the middle is actually a more sophisticated chair. That's an electronic chair, and you can see, I hope you can see on the bottom, there's almost a track, and that track will be responsible for taking the person down the steps electronically. So the chair that is pictured that is yellow is non-electronic. That's just, going down the steps, sort of bump, bump, bump. The one that has a track, the caregiver has electronic controls on a bar, and the machine is doing all the work for you. Also, everybody with ALS, regardless of the respiratory status, should have a go bag. This bag is kept near the door that you would use to exit, or you can have more than one bag if you have multiple exits. And the bag would be grabbed in the event that somebody had to call an ambulance or that you had to evacuate very quickly. And in the bag, you could have whatever you want. You can customize these bags. Now, FEMA has content suggestions that I have listed here, but the most important things would be having written phone numbers. Don't assume you're going to have access to your cell phone. You might have accidentally left it behind, or it might have died. So written phone numbers, communication boards if you have difficulty speaking, your copy of your advance directives. I always tell people to go to Five Below and buy a cell phone charger and leave it in the go bag. Promise yourself you're never going to take it out, all right? And if you do the Five Below, get the 10-foot, because if you end up in a hospital, your outlet might not be right next to the hospital bed. So get the longest cord that you can. It's also recommended, of course, you have hand sanitizer, and for people who have a feeding tube, you might want to include some cans of enteral nutrition. That might be important if you had to leave the house and go to a shelter for a weather-related emergency, because shelters are going to give you hot dogs and hamburgers. They're not going to have cans of feeding tubes or enteral nutrition for you. So customize the bag the way you want, but always have a go bag near the door. Thank you for participating in this webinar, and if you have any further questions, you can feel free to email me at alisa@alsphiladelphia.org, or my phone number is on the slide, and I look forward to speaking with you in the future.